Primary health care is very important in health systems around the world. Often, however, hospital based care receives a lot of funding and attention, and it can be hard to develop a strong, resilient primary healthcare system. That's true in high income settings, but also in low and middle income countries, even though it's incredibly important to have good primary care. That's like your first contact care. It's very important, especially in the context of chronic disease being the primary burden that we face, and population aging trends around the world. And if people need to regularly check their blood pressure, check their blood sugar for diabetes, and have regular follow up every few months, it's more convenient, more cost effective if they can go to someplace nearby rather than go to an expensive hospital based setting. So that's one reason why it's important to think about strong primary healthcare systems. And that's what we chose to study in this setting in Zhejiang province in China. Particularly important in China because high blood pressure is leading preventable risk factor for premature mortality in China and in many places around the world. So in their health reforms, they've been trying to strengthen the primary healthcare, but it's a difficult challenge. China, like many health systems, its neighbors in Asia and elsewhere, have often a hospital-based system with large hospital outpatient departments. And only more recently have they gone back to, China was famous for the barefoot doctors in the Mao era, and more recently have gone back to trying to invest more in that primary care as part of national health reforms. But there are reasons why patients don't trust primary care. Often those physicians don't have as much training or specialized expertise. So it's a critical question that we wanted to help our policymaker co-authors answer in this study. One of the main challenges that China's been trying to address with its health reforms, the popular saying or ubiquitous lament among patients in China is the coming nan, coming gui. Getting healthcare is difficult and expensive, and they've been putting in place universal health coverage to help with this. But when you provide more insurance and allow patients to self-refer to wherever they want to receive care, it actually has exacerbated crowding at major hospitals. And there's a lot of latent capacity, low occupancy in primary health care, which in rural areas of village clinics and the township health centers. So with efforts to try to strengthen primary health care, there have been programs rolled out to manage hypertension or diabetes, these common chronic conditions, at the local level. And we wanted in particular to look at a rural population. The rural hukou residents in the county that we were looking at are over 80% of the population. In part because they're the more vulnerable group. In China in particular, there are large disparities between urban and rural residents as a marker of differential exposures over a lifetime. But China's been trying to invest in closing that gap as part of rapid urbanization and development. So we wanted to specifically evaluate their program of primary care management of hypertension and diabetes as part of the government essential public health service. So what we did was we worked with a Zhejiang CDC chronic disease management department, and I've been collaborating with them for many years. And they were full partners and helped us to define the question that we wanted to analyze and choose a site, which is a county in northern part of Zhejiang province, Tongxiang, a little under a million residents, over 80% rural. Per capita income is about double the national average for rural residents. So we're not claiming that it's representative, but that it's providing a best case scenario, if you will, or proof of concept that in a rural area, you can invest in primary health care and deliver value that is perhaps better management of these common chronic diseases at lower cost, more affordably, closer to home. without leading to worse health outcomes, indeed might have better health outcomes. So we pulled together data from many different sources. In this case, looking over 5 years, 2011, 2015, we have all the data on the primary care management for those with hypertension and diabetes, some 70,000. And then we focused in on a smaller sample for the research design, which I'll mention in a moment. But we pulled together records that are not frequently linked together in study in China. And it is important to be able to look at what's really happening both in overall use of care at the village clinic, but also whether they're going to hospitals. This place is not so far from Shanghai or Hangzhou. Are they going there for their care? So we linked their medical insurance claims, their primary health care, residents' records, health checkup records, so we could look at their blood pressure and blood glucose outcomes. So with this unique data, working with our Zhejiang colleagues, we set out to try to figure out if being enrolled in this primary care management program led to lower use of specialist visits that we defined as going to the outpatient department of the county hospital or other hospitals, more use of primary care, and what that implied for control of their chronic disease. The challenge there is to try to disentangle primary care management from everything else that's going on, and many things are changing in China over time, right? So one of the unique aspects of this study was trying to differentiate correlation from causation. And for that, we used a kind of border design, which is looking at villages managed in different townships because the programs are administered at the township level. And we looked at villages within 2 kilometers of each other, but across the township border, so that they're very similar, and we controlled for all of their resident characteristics. But those people are exposed to different intensity of primary care management in terms of how often people go to their homes or they come into their clinics, whether there's screening of the community, and a lot of effort, follow-ups and so on, to manage the patients enrolled in primary care. So what we found was rather encouraging for the efforts that China's been putting into primary care management of chronic diseases, this very difficult problem. So although overall utilization of care went up quite a lot for both the intensively managed and less managed patients, we found that those that had longer enrollment in primary care management or more intensive management had more visits at their village clinics and township health centers, and fewer visits at hospital outpatient departments, and importantly, about 12% fewer hospitalizations over this time period, and overall lower spending. And some indications that the reason for this was that they had better adherence to their medications and better control, particularly of blood pressure. So for example, those under primary healthcare management for 1 year longer were over 17 percentage points more likely to have their blood pressure under control compared to about half of people in general. So that's effectively like a 33% increase in improvement in blood pressure. And in particular, it was among the most severe patients. So stage 2 hypertension, even larger increase over time in terms of those under control. So this is suggestive that the primary healthcare management may improve net value. That is, that they're not just decreasing spending, but they're actually might be helping to improve health outcomes for the same or lower resource use, rather than restricting care without attention to quality. So although this needs to be looked at many settings and thought about when scaling up, it is rather encouraging. And we looked at a sort of back of the envelope analysis of welfare, just in terms of how much the government is investing in this program and then how much benefit they might be receiving from the program. And we found that the resource savings just from fewer Admissions to hospitals when people are managed more intensively in primary care outweighed the costs of the program. Um, Investment in primary health care are very important. There have been research in the literature. A lot of it has been in high income countries. So it is important to think about the different settings in low and middle income countries and to study the ways to utilize what could be considered a kind of latent capacity of primary health care. In this case and elsewhere, there wasn't a huge increase in the number of people working in primary health care. There was some improvement in training, but that was not the primary mechanism. It was really providing incentives for the people already working in primary care to attract and retain the residents that lived near them in their local clinics and to provide them quality care so they'll want to continue to stay managed there. And there's evidence from many other places, India, a recent very interesting study in Nigeria called Working Hard or Hardly Working, where if you monitor physicians or provide other kinds of incentives, you find that they're actually able to deliver more care and that patients benefit. Or there's a documented no-do gap where physicians know what to do, but they don't actually often do it in their clinic. And that's partly because they may be overwhelmed or they're not rewarded for providing good care. So there's a latent capacity where patients skip over primary care and go directly to hospitals or elsewhere. So if we can gradually scale up these kinds of effective programs at primary care, we can build more resilient, cost-effective, affordable healthcare systems for populations in many different settings. This project is a culmination of a multi-year collaboration with colleagues at the Zhejiang Provincial Centers for Disease Control, particularly those in their Center for Chronic Disease Management. And I've been working with the director Yumin there and his colleagues for many years, first visiting there and talking with them, trying to understand what issues they thought were very important and what kinds of programs they would like to have more evidence about what worked when they're thinking about scaling up or providing evidence from one county or pilot to inform other parts of the province. So after visiting them, they're basically annually over several years and having a colleague from Zhejiang visit Stanford one a year over several years, we built up a relationship looking at different research questions. And this is one of the final research products that we worked on. I look forward to going back to Zhejiang after the pandemic and thinking about further collaborations there and with other colleagues in China. But one of the other important parts of this collaboration was that I worked jointly with two students in the Stanford Department of Economics, and Yiwei Chen, when he was working on his dissertation, went with me for one of the fieldwork visits, and we talked with colleagues there about the policies, the data, what they wanted to learn. And so we've been working together on developing that quantitative analysis, even during a time of sometimes tense bilateral relations. We found it very important to be able to communicate directly and collaborate on an important question, not only for rural China, but for many other parts of the world, and we hope to continue. We work jointly, of course, to assemble the administrative data and health checkup data. And of course, you have to very carefully consider research and the privacy of data in this context. So we went through institutional review board review as an ethics committee, both in Zhejiang and at Stanford University. And as part of that process, we anonymized the records when we were doing the analysis and linking the different parts of the data. And this kind of collaboration where we utilize the data that's available to answer an important question while respecting the privacy of the individuals and hopefully delivering benefits to them through more effective or affordable programs in the future, perhaps is a promising model for researchers here and elsewhere to undertake. There are increasingly efforts at social impact labs or ways of reaching out to communities locally and globally And we at Freeman Spogli Institute and APARC pride ourselves in working collaboratively with colleagues in Asia. And we hope to do this kind of research collaboratively going forward. And we know as a world we'll need to work together to address large changes, including the threats of pandemics, responding to the current one, preventing devastating future ones, having more resilient systems, addressing climate change and other global challenges.